Yes. Hello aspirants. So let me just check, am I audible? Is the screen clear so that we can start the session now? Okay. So this is the anatomy quiz session targeting for FMGE session 2022 June session. So yes. I am audible and you can listen to me. Great. So here this is an MCQ session, and meanwhile the aspirants are joining, I would like to tell you about this session and about myself Dr. Monalisa. I have got a total of 9 years of teaching experience, and here we are going to discuss the important MCQs which is very important for you to solve if you are going to target the June session FMGE examination. Okay, so let's talk about firstly the special class features. So when I am talking about the special class features, here what is important for you that you will be able to, okay, so yes my dear aspirants, okay, so yes, am I audible? So about the special class feature, so when I am talking about the special class where you can be the part of the session, so you can be the part of special classes, and in the special class features you can see all the benefits of joining the special class, where you can interact with the learner, polls are conducted, raise your hands, get your doubts clear right itself when the session is going on. So all these benefits will be availed by you, and this will be highly beneficial for you, my dear aspirants. Okay. And I also want you to tell about and inform you about All India mock test. What is All India mock test? This is going to happen on 19th Feb 9 am. So just be ready for this mock test. This is on the free platform of Unacademy. Get enroll in this test by using the code NAD10. So you can get enroll in this test by using the code NAD10, and this will be highly beneficial for you. I would also like to give the information of the two sessions which I am going to take today. One is the anatomy quiz third, which is targeting for FMGE examination, and which is exactly at 6 p.m. The other session is of conceptual understanding of anatomical terms, which is going to start at 8 p.m. One of the important point which I want to tell about today's session is that today when I will finish the session, we will get connected on the Unacademy app. So all of you must have downloaded the Unacademy app, and those who have not downloaded, they should download the Unacademy app, and they can talk to me, they can ask the relevant doubts of this topic also, and I will tell you about the strategies how to concentrate more on the study and utilize maximum hours of study. So we will connect for 15 to 20 minutes on the conversation. Now let's talk about the plus subscription. When I am talking about the plus subscription, you can access both live and recorded version. You can study from India's top educators, test your preparation with highly conceptual quizzes, study on the device of your choice, assess more than 25,000 MCQs, and soon you will be provided with the printed notes of Unacademy. So these are the benefits of joining the plus course. Use my code NAD10 and get 10% discount. Iconic subscription, the same goes. You get the benefit of plus course. Along with it, you also get the benefits of the prep ladder. And that means you can be the part of video lectures of the Dream Team, QBank 3, active guidance, rapid revision, treasure, dream notes of the prep ladder. That means you will get the best of the two platforms. Congratulations to the toppers of FMGE session. I want to congratulate them, and I am very glad to share their picks with you, and I also wish them best of luck that they can target their NEET PG examination in the first attempt. Okay, this is the pricing detail where the comparison of plus and iconic has been done. Use this code and get an extra discount of 10%. Okay, highly effective QBank is there, where 25,000 MCQs of clinical MCQs of all 19 subjects made by the top educators based on latest pattern of examination, and also a detailed explanation is given for each and every MCQs. So target this and use my code NAD10 to get an extra discount of 10%. Okay, so I also want to tell you about this was valid today only. So okay, let's start with the MCQs now. That is question number 1. So let's start with the first MCQ, that is question number 1. Okay. So which type of joint is growth plate? Okay, my MCQ starts here. So which type of growth plate is the joint, which type of joint is the growth plate? Whether it is fibrous, whether it is primary cartilaginous joint, secondary cartilaginous joint, or plain joint. So yes, your time starts now. Please mark the correct answer, my dear aspirants. Which type of joint is the growth plate? Which type of joint is the growth plate? Which type of joint is the growth plate? Fibrous, primary cartilaginous, secondary cartilaginous, or plain type of synovial joint? So yes, I will provide 30 seconds for each and every MCQs. Okay, so the correct answer for this is primary cartilaginous joint, that is synchondrosis. Let me show you the growth plate. Actually, growth plate is lying at the end of the bone. So in case of long bones, at the end of the bone we have got growth plate, and you can see here the end of the bone is called as epiphysis, and in between diaphysis and epiphysis, this line which you are seeing is the growth plate. After the fusion, bony fusion of the growth plate, further growth of the long bone is not possible, and it is a type of synchondrosis. Which type of joint? Synchondrosis, that is primary cartilaginous joint. Okay, let's move on to the second one. All of the following is an example of composite muscle except. So my dear aspirants, you can see here we have got pectineus, we have got options as pectineus, flexor carpi unlaris, bicep femoris and flexor digitorum profundus. So which of the following muscle is not an example of composite muscle? Okay, so it is very important for you to understand what is composite muscle. When I am using the term composite muscle, it means the muscle having dual nerve supply. The other word which can be used for composite muscle is hybrid muscle. Hybrid muscle means the muscles having dual nerve supply. Okay, now you have to tell me the correct answer and your time starts now. Which of the following is composite muscle? Means all of the following is an example of composite muscle except. So my dear aspirants, I would like to give you the details about the nerve supply of each of this muscle. When I am talking about pectineus muscle, the pectineus muscle which is located in the adductor region of the thigh region, adductor or medial aspect, and this is getting innervation from two nerves. Actually the nerves are obturator nerve, the nerve of medial compartment of thigh. Along with it, it also gets a twig from the femoral nerve, okay, from the trunk of femoral nerve. That means pectineus is an example of, hybrid muscle having dual nerve supply. So this can't be the correct answer. Now moving to flexor carpi unlaris. When I am talking about flexor carpi unlaris, this is only one muscle which is getting just one nerve as its nerve supply. Only one nerve is giving innervation, and the nerve is ulnar nerve, which is a branch of medial cord of brachial plexus. So this is the correct answer because this is not getting innervation from two nerves. Let's move on to biceps femoris. When I am talking about biceps femoris has got short head and long head. Its short head, the short head of biceps femoris is getting innervation from common peroneal nerve, that is common peroneal component of sciatic nerve, and its long head is getting innervation from tibial nerve component of sciatic nerve. So that means it is again an example of dual nerve supply. Okay, now moving on to the last muscle, that is flexor digitorum profundus. Now this flexor digitorum profundus is the deep muscle of the flexor group. It is having superficial, it is having its lateral part and medial part. So write down lateral part and medial part. The medial part of flexor digitorum profundus is getting innervation from ulnar nerve, and the lateral part is getting innervation from median nerve. The lateral part of flexor digitorum profundus is getting innervation from median nerve, and the medial part is getting innervation from ulnar nerve. So it is now clear that all these three muscles, that is pectineus muscle is an example of hybrid muscle, bicep femoris is an example of hybrid muscle, and flexor digitorum profundus is also an example of hybrid muscle except flexor carpi unlaris. Flexor carpi unlaris is the only one muscle which is getting innervation from just one nerve, that is a branch of medial cord, ulnar nerve. So we will go with B as the correct answer, flexor carpi unlaris as the correct answer. Got it, my dear aspirants? So let's move on to the next MCQ, that is MCQ number 3. All the best. Okay, all the best. So let's move on to third number MCQ. So this is a clinical MCQ. Let me read it for you. A 12-year-old boy falls from a tree. He is climbing which he is climbing, but catches himself on a branch with his right hand. So to save himself from falling down, he catches the hold of the tree. He swings by his right arm and jumps to the ground. Several hours later, he presents to the emergency room with right hand clumsiness. Which of the following structure has he most likely injured? Whether the correct answer is axillary nerve, whether the correct answer is radial nerve, musculocutaneous nerve, long thoracic nerve, or brachial plex of the lower trunk. Okay? Okay, yes. Good evening dear. Also, yes. So, we have got 5 options here and you have to mark the correct answer. I would like to highlight the keywords. The keywords are the mode of injury. So, in this case, the mode of injury is, for saving the injury, the boy is catching hold of the tree. So, the boy falls from a tree and he catches himself on a branch. So, he is falling from a tree and to save himself, he catches on his branch of a tree. He swings by his right arm. Several hours later, he has got right hand clumsiness. So, which of the following structure is most likely injured? Okay, so we have got 5 options and your time starts now. Please mark the correct answer, whether it is axillary, radial, musculocutaneous, long thoracic, or brachial plex of the lower trunk. Which is the correct answer, dear? Actually, the correct answer is brachial plex lower trunk. Okay. Now, for answering it correct, if you want to answer this MCQ correctly, it is important that you should know the mode of injury of upper plex and that of the lower plex of brachial plexus. So, I would like to show you that diagram so that you can understand the correct answer here. So, keywords, firstly is to mark the keywords. So, see here in this MCQ, the keywords has been marked, has been written by the red color. As you can see, the keywords here is fall from a tree, catches himself on a branch, swing by the arm, right arm, and right hand clumsiness. Okay. So, the site of injury here described, the site of injury which is described here is the lower trunk injury of brachial plexus. Lower trunk is formed by joining C8 and T1. And the cause of injury, there are various mechanisms of injury. Either the injury can be birth injury, cervical rib. Lower trunk presents anterior to scalenus medial border and lies on the first rib. So, it can also be compressed by the scalenus group of muscle and the ribs, and that can also be one of the reason of lower plex, brachial plex injury. Other than that, it can be elevated by the cervical rib and undue abduction of arm while holding something. Okay. Now, undue abduction of arm while holding something during a fall from a height. So, this is most important and this is the correct mechanism which was mentioned in the MCQ, that if there is an undue abduction of the arm when you want to save yourself and you hold something to save yourself from falling from a height. So, see here, this is the correct mechanism of injury which was mentioned in the MCQ, that is causing the lesion of lower trunk lower trunk brachial plex palsy. So, the person is, or the boy is falling from the ground and is holding a branch of tree, and this will lead to hyperabduction of arm. Other injury can be birth injury, and the third reason can be the cervical rib. Okay, so we have got the correct answer. After that, I would like to tell you about the clinical presentation of the patient if lower trunk palsy occurs. So, it's very important to know the lower trunk palsy is involving which nerve roots. It is involving C8 and T1 and also at times C7, and it will lead to paralysis of intrinsic muscles of the hand and also the ulnar flexors muscles of the wrist and fingers. So, this will lead to injury of muscles of the hand, flexor muscles, ulnar flexors of the wrist and fingers. Okay, the sign and symptoms can be further guided as it is the person will have claw hand and also Froment sinus positive. So, it is very important to know which claw hand. Actually, ulnar nerve is giving innervation to only medial group of muscles. So, it is also giving innervation to medial lumbrical muscles and all interosseous and medial part of the long flexors. So, the claw hand will be more pronounced and will be present only in the medial fingers. So, due to unopposed action of long flexors and extensors and unopposed actions of long flexors and also the extensor muscles over use or action, and the paralysis of interosseous muscles and the medial to lumbricals. We can see the ulnar claw hand in case of C8 and T1 nerve involved. Froment sign, when you tell the patient to hold a piece of paper in between your thumb and that of fingers. So what index finger, what you will see generally when I hold something, I hold a piece of paper. For example, if I am holding something in between, for example, I am holding something like this, a block. So then I am holding it and I am keeping my thumb straight. So it is kept straight, adducted and kept straight. This is the action of adductor pollicis muscle. So when ulnar nerve is paralyzed, this action of adduction is not done by adductor pollicis, and in that case flexor pollicis longus muscle comes in action, and it will hold something by flexing the thumb, by flexing the distal phalanx of the thumb. So this is also seen in case of ulnar nerve injury, and also there will be loss of sensation in ulnar side of hand and forearm. Okay, now see here, this is a case of Klumpke's paralysis. Lower trunk palsy. Here you can see the ulnar claw hand is shown in the medial two fingers. Okay, other than that, I would also like to show you this other features of Klumpke's paralysis. So let me just enlarge this image. So when I am enlarging this image, you can clearly see that Froment sign is positive, and here you can see here the thumb is in adducted position or straight. It is in adducted position and normal condition when the adductor pollicis muscle is active because ulnar nerve is not injured. Here in this case, you can see there is flexion of distal phalanx of the thumb, and the reason of flexion of distal phalanx of thumb is by the action of flexor pollicis longus muscle. So Froment sign positive, and also the dorsii interosseous muscle you can see here. Here there is if you will see this diagram, here you can see there is concavity which is showing you the loss of dorsal interosseous muscle is paralyzed. So these muscles are paralyzed. So these are the key features which are seen in case of lower trunk palsy. Other than that, let's come on with the further explanation. Also, one of the important feature which is seen in case of lower trunk paralysis of lower trunk palsy in case of brachial plexus is Horner syndrome. Why? I will tell you. The root values which is involved basically is C8 and T1. Okay, now here T1 fibers are also carrying sympathetic fibers along with it, and because of that, because of involvement of sympathetic fibers, Horner syndrome is seen in the case of lower trunk palsy. So the presentation of the patient will have ptosis, that is drooping of upper eyelid, miosis, constriction of pupil, anhidrosis, absence of sweating, anophthalmos, that means sunken eyeball. So these are the features associated with that. In overall, you can see Horner syndrome is associated with Klumpke's paralysis or that of lower trunk palsy. Due to disruption of the sympathetic fibers of head and neck, it will which is traversing via T1, it will be seen in case of lower trunk palsy. Now, let me talk about upper trunk palsy. What I told you in brief, we will also talk about upper trunk palsy. Actually, for your FMG aspirants and for your FMG examination, brachial trunk palsy is a very important topic. So what happens here in this image, you can see the vaginal delivery is done, and in case of difficult vaginal delivery, undue hyperabduction is done. In case of difficult vaginal delivery and undue suppression of head and neck is done, in that case there is stretching of the neck, and this will lead to upper trunk palsy. Now, in upper trunk palsy, mainly the nerve root which is involved is C5 and C6, and the point which is involved is the upper trunk, where 6 nerves are meeting. So here C5 and C6, also CD is anterior division and that of posterior division of nerve, and these are the C5 and C6 root value. Okay, so these are the nerves which is meeting here. So here we will have C5 and C6 nerve root. Here the two nerve branch, that is suprascapular nerve and that of nerve to subclavius. These are two branches of upper trunk which also meets here. So total 6 nerves meets at this point. The lesion of upper trunk palsy is called as Pullishman tip deformity. Pullishman tip or waiter tip deformity. So in this case, what happens, the arm hangs by the side. As you can see, in the arm is hanging by the side, and also forearm is extended and pronated. So actually you can see in this baby, it appears like the forearm is extended, pronated, and the money is asked from behind. So it is called as policeman tip or waiter tip deformity. Okay, so the case here you can see the adduction of the arm hangs by the side, and the presentation of the patient will be adduction and medially rotated arm, and extension of elbow and forearm is pronated. The condition is called as policeman tip or waiter tip deformity. So yes, done with this. Let's move on to the next, that is question number 4. So all the best to everyone. So this is another clinical MCQs. So MCQ, let me read it for you. Okay. A 30-year-old man underwent excision of right radial head. Following the surgery, the patient developed inability to extend the fingers and the thumb of the right hand. He did not have any sensory deficit. Which of the following is most likely the reason or the cause? A. So, injury to posterior interosseous nerve, iatrogenic injury to common extensor origin, injury to anterior interosseous nerve, high radial nerve injury. Okay, so we have got 4 options. You have to give the right answer. Again, I will tell you the key points here. Key point is excision of right radial head. And after the surgery, the patient is unable to extend the fingers and the thumb of the right hand. Inability to extend the finger and the thumb of the right hand. No sensory deficit, very important, no sensory deficit. Only extension of fingers and that of the thumb of right hand is involved, and radial head is excised. So the key feature is given, and you have to give me the correct answer, whether it is high radial nerve injury, injury to anterior interosseous nerve, iatrogenic injury to common extensor origin, or injury to posterior interosseous nerve. So please mark the correct answer. Your time starts now. Yes. Okay, so my dear aspirants, here the correct answer is injury to posterior interosseous nerve, and I will explain you why. So injury to posterior interosseous nerve is the correct answer. The reason is that the deep branch of radial nerve is involved. Here the deep branch of radial nerve is involved. Here the deep branch of radial nerve is injured. And why not the other reasons? Because no sensory deficit, no involvement of sensory branches. So that means deep branch of radial nerve is involved. So only extension is involved. So only the extensor origin is affected is not the reason. Okay, that would not be the reason, because the 30-year-old man is having a right radial head involved, excised, and after the surgery there is the inability to extend fingers and the thumb. Also high radial nerve injury is not the answer, because in that case both motor and sensory loss will be there. Both motor and sensory loss will be occur in the high radial nerve injury. Now, injury to anterior interosseous nerve is not the right answer, because anterior interosseous nerve is deep branch of median nerve, and when it is involved, the loss of flexor action will be there. The loss of flexion of elbow and flexion of the wrist will be involved, not the extension. So flexion of fingers, flexion of the wrist will be the involved, but not the extensor loss. So it is A is the correct answer, that is injury to the posterior interosseous nerve, deep branch of radial nerve. Okay. So let's move on to the next. Which is not a branch of facial artery? Which of the following is not a branch of facial artery? Inferior labile artery, superior labile artery, lateral nasal artery, angular artery, or retromandibular artery? According to you, which is the correct answer? Your time starts now. Okay, which is not a branch of facial artery? Inferior labile artery, superior labile artery, lateral nasal artery, and angular artery, or retromandibular artery? Which is the correct answer? 5 options are there. So the correct answer is retromandibular artery. So we have got retromandibular vein, and this retromandibular artery is not a branch of facial artery. All other branches which is mentioned here is the branch of facial artery. Facial artery itself is a branch of, itself is a branch of anterior branch of external carotid artery. Okay, it itself is a branch of external carotid artery, and all other are the branches of facial artery. Let me show this image. So in this image you can see the branches of facial artery on the face. So you can see here facial artery is running over the mandible, over the crossing the base and the mandible, and it is giving various branches. It is giving angular branches, lateral, nasal, superior and inferior labile artery, which is going towards the superior inferior aspect of the lips, towards the upper and lower lip area, and also the lateral aspect of the nose and going towards the medial aspect, medial canthus. So this is exactly shown here, and these are the branches of facial artery, not the retromandibular artery. Let's move on to the next MCQ. Primary curvature of spine are, which of the following is regarded as primary curvature of the spine? So please mark the correct answer, whether we have got primary curvature of spines located in the thoracic region, cervical region, lumbar region, or none of the above. Which is the correct one? Which is the correct one, my dear? So among the 4 options given, which is the correct one? Okay, primary curvature of spine are, so here thoracic region of the vertebral column is the correct answer. Primary curvature of spine are, the thoracic region of the vertebral column will be the correct answer. Actually both in cervical and lumbar region we have seen secondary curvature. There is secondary curvature. So actually primary curvature means the same curvature as seen when the fetus was inside the womb. Now after delivery, what happens when the baby is born? When the baby start getting head holding, so the baby start holding its head by approximately 4th month and 5th month, then cervical curvature is appearing, and when the baby start walking and standing, then the lumbar curvature is formed. So I would like to show you this. So please firstly note down, thoracic and sacral kyphotic curves are actually primary curvature, and when the baby is lying in the embryo, when the baby is lying in the womb, and in that case what happens, the whole flex curvature of the baby, of the developing fetus is seen, and if it is continued after the delivery also, so that is called as the primary curvature. But due to certain features or milestone achieved by the baby, that is neck holding features, standing, walking, the other curvatures which is seen is the cervical and the lumbar curvature. So these are secondary, they are formed after the baby is born. So I would like to share this image where you can clearly see. Okay, so that means in case of lumbar region and in case of cervical region, what you can appreciate, that both of this is having convexity anteriorly. So these both are having convexity anteriorly. So that means that means these are secondary curvatures which is formed after the birth. Now, but the thoracic region and the sacral region are maintaining concavity anteriorly. So they are maintaining concavity. They are concave anteriorly, same as when it was lying inside the womb. So these are 2 examples of primary curvatures. Got it? These are 2 examples of primary curvatures. So yes, let's move on to the next MCQ. There are no Tinea coli in which of the following reason? There is absence of Tinea coli in which of the following reason? Your time starts now. Please mark the correct answer. Whether the absence of Tinea coli is in the ascending colon, descending, transverse, sigmoid, or appendix. Which is the correct answer? There are no Tinea coli in. There is absence of Tinea coli in which of the following location? ascending colon, transverse colon, descending colon, sigmoid colon, or that of appendix? So here the correct answer is appendix. I am going to explain you why. What is the reason that appendix is the correct answer? Actually, we know that large intestine has got three cardinal features. One is hostration, other is presence of Tinea coli, and that of epiploid appendices. So actually Tinea coli is the longitudinal muscle coat, they are like in the form of three ribbon which is running, longitudinal muscle coat is running over the entire large intestine. Okay, so it is a cardinal features, but Tripathi is absolutely right, and it is appendix is the correct answer. Yes. So yes, we have got correct answer. This is appendix is the correct answer. Now, my dear aspirants, actually what happens, all these Tinea coli will converge at the base, all the Tinea coli converge at the base of appendix. All the Tinea coli converges at the will converge at the base of the appendix, converge at the base of appendix. Okay, converges at the base of the appendix, and this is exactly the correct answer. Other than that, all other location we have got so actually rectum is also a location where Tinea coli is absent. Other than that, ascending, descending, sigmoid, descending, transverse colon is containing Tinea coli. So see here, there are no Tinea coli in the appendix as you can see in this diagram. So this is the three bands which has been shown here. Actually these longitudinal bands, so what is these are longitudinal muscle coat band which is running over the surface of the large intestines, running over, except in the case of rectum and that in the case of appendix. Actually in case of appendix, all the Tinea coli, if you will see, they are converging at the base of appendix. This is what, this is the tip or the apex of the appendix, and all Tinea coli are converging at the base of appendix as shown in the diagram. Let me move on to the next MCQ. See here, this is again, so before moving on to the next MCQ, one more diagram I want to show you, which is showing you here again you can see this is the rectum, and here also you can appreciate the rectum is having no Tinea coli. Rest whole part, as you can see here, the Tinea coli are located, ascending, descending, transverse colon, and entire part of large intestine, but not in the appendix, no Tinea coli in the appendix and no Tinea coli in the rectum part. Let's move on to the next MCQ, that is MCQ number, okay, question number 8. Okay, all the best. So while exposing the kidney from behind, all of the following nerves are liable to injury except. So when we are exposing the kidney from behind, means when we are actually we know that kidney is a retroperitoneal structure, so it becomes easy for us to approach the kidney towards behind. So certain that means if any of the structure which is related to the posterior aspect of the kidney can get injured. So you have to tell me which of the following structure or which of the following nerves which is given in the option: lateral cutaneous nerve of thigh, ilioinguinal nerve, subcostal nerve, or iliohypogastric nerve. So which of these following nerves are not liable to get injured, is not liable to get injured, means they are not related in the posterior aspect of the kidney. So 4 options are there, mark the correct answer. Question number 8. So yes, okay, I got an answer B. So B is okay. So what about others? Okay. Okay. So actually the correct answer will be lateral cutaneous nerve of thigh. The correct answer is lateral cutaneous nerve of thigh. So I would like to show you the posterior surface of both the kidney, right and the left hand kidney, and also I would like to appreciate the relations of posterior part of the kidney. So see here in this diagram, Firstly, it is very important for you to know that we have got, if we see the relations of the rib. So, if you will see the relations of the rib, what you can appreciate that in case of left kidney, 2 ribs are related, 11th and 12th. But in case of right kidney, only 12th rib is related. So, what is the reason? Can anybody tell me? The reason is that here in the right hand side, so in right hand side we have got a heavy weighted. So, in right hand side we have got a largest organ of the body lying superiorly, and that is the liver, which is lying superiorly. So, we have got liver superiorly. So, ribs relation for both the kidney is 11th and 12th. 11th and 12th both ribs for the left kidney, but only 12th rib for the right kidney. So, we have done with this. Now, let's move on to the nerve muscles. So, let me tell you about the muscles. So, see here, actually 3 muscles are related on the posterior aspect. 3 muscles are related on the posterior aspect. The muscles are, medial most muscle will be the psoas major muscle. So, muscles are related on both the side medially. The medial most muscle will be psoas major muscle as shown in the diagram. This is the psoas major muscle. Now, intermediate level we have got the quadratus lumborum muscle. So, this is the quadratus lumborum muscle, and most laterally we will have the transverse abdominis muscle. So, this is transverse abdominis muscle. So, it is quite clear that we have got 3 muscles related posteriorly, quadratus lumborum intermediately, psoas major medially, and transverse abdominis laterally. Now, it comes about the relation of nerves and vessels. So, subcostal nerves and vessels are related, and below subcostal nerves and vessels. So, see here, subcostal nerves and vessels, this is the subcostal nerve, this is iliohypogastric nerve, and this is ilioinguinal nerve. Subcostal nerves, iliohypogastric, ilioinguinal nerve. So, these nerves, iliohypogastric, ilioinguinal nerves and subcostal nerves and vessels are related in both right and the left hand side. And with red and blue color you can see subcostal vessels and nerves are related. And on the also the marking of arcuate ligaments of the diaphragm. So, diaphragm is related on both the side, and also green color is showing you the markings of arcuate ligament of the diaphragm. So, here we can clearly see which structure or the nerve is not related, that is the lateral cutaneous nerve of thigh is not lying in relation on the posterior aspect of kidney. So, we will mark A as the correct answer. Okay, my dear aspirants, let's move on to the next MCQ, that is question number 9. Clavipectoral fascia is pierced by which of the following structure? Clavipectoral fascia is pierced by which of the following structure? Whether it is axillary vein, whether it is axillary artery, brachial artery or cephalic vein, which is the correct answer? Clavipectoral fascia is pierced by which of the following structure? Axillary vein, axillary artery, brachial artery or cephalic vein? Mark the correct answer. So, the unexpected turn has given, okay, so okay, so yes, let me give you the right answer. The correct answer here is cephalic vein. So, clavipectoral fascia, we know that clavipectoral fascia is extending from lower aspect of the clavicle and merging with the axillary fascia, and it is enclosing. So, please wrote down clavipectoral fascia, which is lying deep to pectoralis major muscle, and this clavipectoral fascia is enclosing 2 muscles. It encloses 2 muscles. The muscles are 2 muscles. So, the muscles are subclavius muscle, the first muscle, and the other is pectoralis minor muscle, pectoralis minor muscle. Okay. Now, my dear aspirants, I would also like to tell you 4 structures. So, clavipectoral fascia is pierced by 4 structure. Clavipectoral, so please write down clavipectoral fascia. We know that 4 structures pierces is, the structures are, if you want to write it, I will also show in the diagram: lateral pectoral nerve, cephalic vein, thoracoacromial artery, and that of lymphatics, Okay, so yes, see here these 4: thoracoacromial artery, so it's thoracoacromial artery, cephalic vein, lateral pectoral and lymphatics. These are the 4 structures which is piercing clavipectoral fascia. So, here we will mark cephalic vein as the correct answer. So, we will having cephalic vein as the correct answer. So is it okay? Let's move on to the next one. That is question number 10th. Epithelial lining of prostatic urethra. What is the epithelial lining of prostatic urethra? Whether it is stratified cuboidal epithelium, whether it is stratified columnar epithelium, whether it is transitional epithelium, or whether it is stratified squamous epithelium. What is the correct answer? Question number 10th, we have got 4 options. Okay. So this is A, stratified cuboidal epithelium, B is stratified columnar, transitional epithelium is C, and D is stratified squamous epithelium. So according to you, which is the correct answer? Lining epithelium of prostatic urethra. So histology, in case of histology, epithelium is a very important topic. So the correct answer is transitional epithelium, which is also called as urothelium. Transitional epithelium is lining initial part of urethra, ureter and urinary bladder. So initial part of urethra, urinary bladder and ureter, these are the structures which is lined by transitional epithelium, which is also called as urothelium, which is having the property of stretchability. Got it? Yeah, let me so actually when we see the case of male urethra, we have got various parts in the male urethra, and it is important for you to know the different part lining epithelium. If I take the example of pre-prostatic and prostatic part of urethra, if I take an example of pre-prostatic or prostatic part of urethra, what is the lining epithelium? The lining epithelium is transitional epithelium, which was asked in this MCQ. Okay. Lower down, if we go in the membranous part of urethra, membranous part of urethra is traversing in which part, in which muscular structure? Urogenital diaphragm. It is lined by pseudostratified columnar epithelium. Pseudostratified columnar epithelium. The bulbar and the penile part is lined again by pseudostratified columnar epithelium. It is also lined by pseudostratified columnar epithelium. Moving further down, we have got navicular fossa, and navicular fossa is more towards the terminal end, so its lining is stratified squamous non-keratinized epithelium. When it is continuous with the glans penis and the skin at the glans penis, so we have got the same epithelium as the skin, so it will be stratified squamous keratinized epithelium. So for memorizing, what you can memorize like this: the part which is lying very close to the skin, which is ultimately ending at the skin, will have similar epithelium as the skin, that is keratinized, stratified squamous keratinized. We know that navicular fossa is lying very close to that of the distal aspect and towards the skin, so it is stratified squamous non-keratinized. The middle part will be having pseudostratified columnar epithelium, and we know that initial part of the prostate is lying close to the urethra, so it's lying very close to urethra, so it will have transitional epithelium. Okay, let's move on to the next. Fundus of gallbladder lies in an angle between lateral border of rectus abdominis and the tip of 9th costal cartilage. The vertebral level is at the lower border of, what is the vertebral level? That means you have to tell the corresponding vertebral level of fundus of gallbladder. 2 hints are provided. One is fundus of gallbladder, which is the hint provided to you. Other is tip of 9th costal cartilage. So these 2 structures are located corresponding to which vertebral level? T11, T12, L1 or L2. Which is the correct answer, my dear aspirants? T11, T12, L1 or L2. Here the correct answer is L1. Actually, when we are talking about fundus of gallbladder, 9th of costal cartilage is corresponding to transpyloric plane. It is lying at the level of transpyloric plane, which is also called as adhesive plane, and it is lying at the vertebral level L1, first lumbar vertebra. So I would like to show you this diagram where you can see this is the transpyloric plane, which is corresponding to the fundus of the gallbladder. It is passing across the fundus of gallbladder and tip of 9th costal cartilage, also corresponding to tip of 9th costal cartilage, and posteriorly it is corresponding to the level of first lumbar vertebra. Okay, so that is called as transpyloric or adhesive plane. Now see here, transpyloric plane, also known as adhesive plane, is an imaginary plane which is lying midway between the jugular notch superiorly. Jugular notch is lying in the superior aspect of manubrium sterni and lower down the pubic symphysis. Okay, so in between jugular notch and pubic symphysis, midway, the corresponding plane which is passing is called as adhesive plane or transpyloric plane, and it is corresponding to the level of L1 lumbar vertebra. It is corresponding to the L1 lumbar vertebra. Got it? Now my dear aspirants, for your exam point of view, it is important that you should know all the structures, you should know the list of structures located at transpyloric plane. List of structures located at transpyloric plane. The structures are pylorus of the stomach, part of the duodenum, first part, DJ junction, root of transverse mesocolon, hepatic flexors of colon, splenic flexor of colon, also the fundus of gallbladder, neck of pancreas, and we know that at the neck of pancreas there is formation of portal vein. So formation, see here, splenic vein and superior mesenteric vein is formed behind the neck of pancreas. So formation of portal vein, both the hilums of kidney and spleen, 9th costal cartilage which was asked in the MCQ, and also the fundus of gallbladder was asked in the MCQ. Termination of spinal cord, that means we know that lower end or termination of spinal cord is forming a that is called as conus medullaris. Origin of superior mesenteric artery is also at the level of L1, and it is also corresponding to the transpyloric plane. So all of you please by heart. Why I have given you this list? You can by heart the structures which is residing at the level of transpyloric plane or adhesive plane, an important question of MCQs. Let's move on to the next, that is question number 12th. All the best. Question number 12th. So we have done with this. Everyone, for your MCQ, please note down all the structures lying at the level of transpyloric plane. Okay, let's move on to the next. Among the following, the content of cavernous sinus is, among the options which is given, which is the content of cavernous sinus. So content, you have to emphasize on this word, content of cavernous sinus. Which of the following structure is content of cavernous sinus? The options are maxillary division of trigeminal nerve, ophthalmic division of trigeminal nerve, trochlear nerve, or internal carotid artery. Cavernous sinus is a very important topic for your FMG examination. So please revise the topic of cavernous sinus. Which is the correct answer? Question number 12. It doesn't matter right or wrong. You can say A, B, C, D, anything you can say. It doesn't matter right and wrong. Okay. Which is the content of cavernous sinus? 4 options are there. That means the structure should pass to and fro inside the cavernous sinus. So actually internal carotid artery is the correct answer. When we are talking about the term content of cavernous sinus, it means actually 2 structures are passing in and out, internal carotid artery, and along with internal carotid artery we have got abducens nerve, that is 6th cranial nerve. These 2 structures are traversing to and fro from the cavernous sinus. Okay. Yes, absolutely right, Nayan Tripathi, absolutely right. Now see this diagram. When you will see this diagram, what you can appreciate that if I enlarge this diagram also, you can appreciate here. This is the outline of the cavernous sinus. Okay, this is lying on either side of the sphenoidal body, and here in the cavernous sinus we have got following nerves. So in the lateral wall we have got 4 dots I will put on. These are oculomotor nerve, trochlear nerve, ophthalmic division of trigeminal nerve, and maxillary division of trigeminal nerve. So these are 4 nerves which is lying in the lateral wall. Now what we have to concentrate on the structures passing to and fro. So inside we will have abducens nerve, and still inside we will have the internal carotid artery. So internal, so that means ICA, internal carotid artery, and abducens nerve, these are 2 structures which is passing to and fro in the cavernous sinus. So we will mark this as the correct answer. Okay, got it? Let's move on to the next. So also I want to show you this diagram where you can appreciate communications and tributaries of cavernous sinus. So communications and tributaries. Communications are via draining channels, superior inferior petrosal sinus, which will drain into transverse sinus and internal jugular vein, And facial vein via emissary vein, pterygoid venous plexus, it can drain infection from dangerous area. Basilar plexus can drain infection to internal vertebral venous plexus. The tributaries are, that means direct tributaries mean direct draining into cavernous sinus. The source is from the orbit. From the orbit, three sources are there: superior, inferior. We have got three sources: superior ophthalmic vein, inferior ophthalmic vein, and central vein of retina. From meninges, we have got two sources: middle meningeal vein and sphenoparietal sinus. From the brain, two venous source is there. One is inferior cerebral vein and other is superficial middle cerebral vein. Actually, very important for you to know, it's very important for you to know is the tributaries. You can't forget tributaries of the cavernous sinus from three sources: brain, meninges and orbit, and communications. That is important. Let's move on to the next MCQ, that is MCQ number 13. The lateral border of Hasselbach triangle is formed by, the lateral border of Hasselbach triangle is formed by which of the following structure? Rectus abdominis, obliterated umbilical artery, inferior epigastric artery, or inguinal ligament? Which is the correct answer? The lateral border of Hasselbach triangle is formed by which of the following structure? Rectus abdominis, obliterated umbilical artery, inferior epigastric artery, or inguinal ligament? Which is the correct answer? Okay. So, actually Hasselbach triangle is also called as inguinal triangle. It is also called as inguinal triangle. You can memorize its boundary by a mnemonic rib. Okay, that means medially it is bounded by rectus abdominis, medially by rectus abdominis. Yes, Nan, absolutely correct, Nan Tripathi, you are absolutely correct. Inferior epigastric artery is forming its lateral border. Obliterated umbilical artery is not forming any border. Inguinal ligament is forming its inferior border. It's forming its inferior border. That means laterally it is bounded by inferior epigastric artery. So, Nan Tripathi, you are absolutely correct. You are absolutely correct, dear Nan. So, yes, inferior epigastric artery is the correct answer. Okay. Okay. So, I would also like to tell today that when I will end the session today, all of you can join me in conversation. So, we can talk about how to pay more attention to the study, how to crack the examination, some tips and tricks, and you can connect me via, I will directly speak to your queries regarding this topic. You can connect me through open house session, which will be taken just when I will end the session. We will start in another 2-3 minutes. Okay. So, all of you be connected, and on your Unacademy app. Unacademy app of your, which you have downloaded in your mobile, and there you can see the link of open house, and you can get connect to me directly. Okay. So, yeah, now let me tell you about the inguinal or Hasselbach triangle. So, here I would like to outline this pink color area which I am outlining with this black borders. What is this? This is the inguinal triangle. Let me highlight this. This is the inguinal triangle. Now, this is also called as Hasselbach triangle. Here you can appreciate that inferior epigastric vessels is forming its lateral boundary. It's forming its lateral boundary. And here rectus abdominis muscle, what you can see, this is the rectus abdominis muscle, and we know that rectus abdominis muscle is lying medially. So, this is forming its medial border. This is forming its medial border. Rectus abdominis muscle will form its medial border. Inferior epigastric vessels will form its lateral border, and inferiorly you can see with yellow color what is shown is inguinal ligament. So, inguinal ligament will form its inferior border. So, yes, we can memorize its borders by a mnemonic RIP, rib. Okay, here we know that inguinal ligament is also called as Paupart's ligament. So, this will give you an idea of, so Paupart's ligament for inguinal ligament, and this is showing you the boundaries. RIP is the mnemonic which is showing you the boundaries of inguinal triangle or Hasselbach triangle. Is it okay? Okay, my dear aspirants, so let's move on to the next one, that is question number 14. Which of the following area is involved in tibial nerve entrapment. So which of the following area is the reason of tibial nerve being compressed? Tibial nerve being compressed. Medial malleolus to calcaneus, lateral malleolus to navicular, medial malleolus to calcaneal tendon, lateral to malleolus to peroneus, long plantar ligament or peroneus longus. So which is the correct one, my dear aspirants? Tibial nerve entrapment occurs due to which of the following structure? So actually tibial nerve can get compressed below the flexor retinaculum, and the correct answer will be medial malleolus to that of calcaneum. I would like to show you that diagram for it. So see this diagram, here you can see the flexor retinaculum of the foot, and the flexor retinaculum of the foot is extending, as you can see, from medial malleolus to the medial tubercle of the calcaneum. So it is extending, as you can see here, it is extending from medial malleolus to the medial tubercle of calcaneum. It is extending from medial malleolus to the medial tubercle of the calcaneum bone, and here superiorly lies the medial malleolus, lower end of the tibia. The structures which is passing from medial to lateral, the structures are tibialis posterior tendon, flexor digitorum longus tendon, posterior tibial artery, and the veins covering it, tibial nerve, and flexor hallucis longus tendon. So all these structures which has been shown are the structures which is passing below this flexor retinaculum. So can you appreciate here tibial nerve was asked in the MCQ, and here you can clearly appreciate that tibial nerve can be compressed by the flexor retinaculum, which is attached to two important structures, medial malleolus and that of medial tubercle of calcaneum. So also it is important that you should know all the structures traversing below flexor retinaculum of the foot. Posterior tibial, that is the posterior tibialis posterior tendon, flexor digitorum longus, posterior tibial artery, and that of tibial nerve and flexor hallucis longus tendon. Okay. So let's move on to the next. That is question number 15. Navicular fossa is located in. Where is the navicular fossa located? It is located in glans penis. It is located in prostate gland. It is located in bladder. It is located in seminal vesicle, or expanded in clitoris. Which is the correct answer? Navicular fossa is located in which of the following location? A, B, C, D, E. Navicular fossa is located in which of the following location? "30 seconds will be provided to you. So the correct answer is glans penis. Let me show you. Okay, glans penis is the correct answer. See here. So here in this diagram you can see pre-prostatic is below, is just above the prostate, and prostatic urethra is lying in the prostate gland, and also the membranous urethra is lying in urogenital diaphragm. Now here you can see this is the glans penis which has been asked in the MCQ, and you can see here in the glans penis what structures is lying, this dilated part that is called as navicular fossa. So exactly, navicular fossa is located in glans penis part of the penis. So this is absolutely correct answer. With this diagram you can appreciate it. Okay, Rahul Gujjar, yes, Rahul Gujjar, okay. Everyone, so yes, before ending the session, what I want you to tell that today I am going to take two sessions. On the future Unacademy, I am going to take 8 PM session, that is of conceptual anatomy, in which osteology points and differences of the bony projections and all I will explain, which was asked by few students, and this was the third part of anatomy quiz. Now I will start with open house, where I will discuss the strategy, how to conquer a good mark in your examination, and how to concentrate and productive hours. Okay, so we will discuss right now. You can get connected to me via, you can open your Unacademy app in your mobile, and there will be the link where you can connect and you can get connect to me, and we can have a talk and discussion. Okay, you can use my code and add 10 if you want, if you are using the platform for the first time, for unlocking it. And also I want to give you the information regarding the All India mock test going to happen on 19th Feb 9 AM. Enroll for this free test by using my code and add 10. Use my code and add 10 and enroll here. Also, before ending, I would like to show you this plus and iconic subscription pricing detail. Anybody who is interested can use my code and get 10% discount. So thank you, all the best, keep studying, and my dear aspirants, you can join me on your Unacademy app, and you will get a link where the link of my session of open house is there. All of you, if anyone is interested for having direct talk and you want to discuss any of your queries regarding this session or any doubt of this MCQs, or I will also discuss the how to concentrate more. Yes, Rahul Gujjar, you can again connect to me at 8 p.m. session on the Unacademy Future Doctors, or you can connect to me on the just I am going to end this session because I have to start the session of open house. So you can talk to me. Just open your Unacademy app on your phone. Okay, all the best, keep studying. Thank you so much. Thanks dear.